Welcome back to Kings and Queens of Miniature Castles. Today with me is Dr. Andrew Peltier of Internal Medicine. Andrew, let's just hop right into it. Tell us about yourself.
All right. So, going way back, grew up in Lakeville, Minnesota. I did not have any medical people in my family. No doctors, nurses, pharmacists, physical therapists, anything to guide me toward or away from medicine as it may have been. Didn't really think about a career in medicine until high school. Started, I think, a conglomeration of a few things. Started taking more science classes. I remember as a sophomore taking an anatomy and physiology class, really liking just learning about how the human body works. And at the same time was starting to run cross country and track. Hadn't really done a lot of sports prior to that, and just interested in the kind of human performance side of how our physiology works. So that was kind of the first spark of interest in medicine. To further explore that, after my junior year of high school, did an internship at the Park Nicollet Clinics in Burnsville, Minnesota, both in their clinic and hospital. And it was a kind of a set rotation, applied for this program and rotated with many different specialties of medicine and physical therapy, and was in the OR on the hospital side, and really could see myself doing some of those. And so that kind of kept me going on that pathway toward considering, looking at pre-med for undergrad, and continue that path. Studied biochemistry at St. Thomas for undergrad. And, pre-med isn't a major per se. It's like a pathway, but you have to have an actual degree for your major. So biochemistry was the degree. And kind of had a somewhat boring pathway, I guess, through all of life. Just plowed straight through, went to med school at the U of M right after that, and further explored different specialties, and settled on a career in internal medicine. And after residency in internal medicine at Abbott Northwestern, I moved here to Cambridge, and have been practicing here in Cambridge since then for coming up on 14 years now.
Okay. And all right, yeah, undergrad, grad school, residency, are we looking at like 10-ish years of schooling?
Yeah, so 4 years of undergrad, and then medical school is 4 years total. And then depending on what residency you do and potential fellowship, the shortest residency is 3 years. So I guess it's 11 years minimum post high school graduation.
Whew. It's a lot of dedicated work right there.
Yeah.
All right. So within that, how did you decide on internal medicine, and what kind of separates it from, being a medical doctor or anything like that?
Yeah, so I guess I'll go back to high school and college again. When I initially got interested in medicine, was thinking a little more on the sports medicine, rehab, maybe orthopedic surgery line of thinking. That was kind of my intro, was interest in sports, and again, track and running injuries and things like that, helping people heal up from those. But in college, in terms of the question about how did I shift gears to internal medicine, I took a job as an assistant at a little private practice, a two-physician internal medicine private practice. I didn't have any specific training, but essentially was a nursing assistant as an undergrad with no real background, but learned to check blood pressures and room patients and do vitals and do basic office work and whatnot. And just saw how these two internists functioned, and they'd kind of, share very basic medical stuff with me when they had an interesting patient, explain some of the physiology. And, internal medicine is it's kind of the specialty for nerds. And let's just be honest, I'm kind of a nerd. so it was the right fit for me.
Sounds like it.
Right. As it turns out, I probably wouldn't have been as adept with hammers and drills and nails and the carpentry side of orthopedic surgery, things like that. I'm better at using my brain to solve puzzles. So internal medicine is kind of the taking a lot of complex, often chronic diseases, and kind of putting together, whether it's a diagnostic plan of mysterious symptoms or, taking patients who have, several different medical problems where you can't necessarily treat any of them in isolation. Like what you might do to optimize one problem is going to have detrimental effects on another. So you really have to kind of coordinate a lot of moving pieces. So I see it very much as a kind of puzzle solving dilemma and working through those things.
Gotcha. Is there, I don't know if this is the best way to phrase it, but is there kind of like what's kind of like the success rate of it if there's like so many different like moving pieces that you're trying to quantify for?
Yeah. I guess that gets kind of at, what our classic medical model is. It's very much, for better or worse, in internal medicine, we're mostly, taking a lot of complex medical problems that are already there. So, this kind of gets at philosophy of, a reactive approach to a proactive approach. And I'm very much, in favor of promoting wellness and not just fixing disease. But the reality is I'm not as far upstream in the process as promoting wellness as I'd like to be. There are a lot of other areas of medicine and kind of complementary, disciplines that are a little more upstream and trying to keep people healthy. But mostly I'm seeing patients, once, a number of symptoms or diseases have set in. Many of them are kind of our classic first world diseases that tend to go along with a more affluent lifestyle and changes in our diet and less need for physical activity because we don't do as physical jobs in general, or many of us don't anymore. So, taking the person who's, unfortunately developed diabetes and has high blood pressure and has had, a heart attack and has stents put in and are on blood thinners or antiplatelet medications for that, and, may also have some COPD or lung disease, maybe has some kidney disease. And so in terms of success rates, we a lot of these things tie together. So if you're, treating one thing, like, for example, lowering blood sugars for someone with diabetes is also going to help prevent having another heart attack, or it's going to help preserve kidney function. But it's always a delicate balance. If a medication is going to lower blood pressure, but potentially have a detrimental effect on kidney function. We need to really be careful about what medications we use, and talk about how to promote healthy diet, lifestyle, all those things to help control all these diseases.
So then kind of you end up, sounds like maybe have like a little bit more of a long-term patients then with a lot of these scenarios.
Yeah. So even within internal medicine, I'll just kind of go back to the basics of internal medicine and residency program. So after completing med school, if you're interested in internal medicine, do a 3-year residency in general internal medicine. That's mostly hospital based. Usually there's like a 1 day or a half day of clinic per week through many of your rotations, but predominantly hospital. Finish your residency in 3 years, and then you have a decision to make. You can either go into practice with that training, which basically options are to become a hospitalist, which is becoming more popular and is probably the majority of general internal medicine doctors now work exclusively in the hospital, or you can do clinic-based internal medicine in primary care. Or you can do a combination. So kind of my pathway was I came out of residency, I took a job here in Cambridge, and at that time, that was 2011, there were 8 providers here, both family medicine and internal medicine primary care providers who still had pretty traditional primary care practices, meaning they had their panel of patients who they saw longitudinally in clinic, but they saw them in the hospital as well. If any of their own patients was admitted to the hospital here in Cambridge, then we would round on them, take care of them in the hospital, kind of just basically provide the vast majority of their medical care, as long as they could stay in Cambridge and didn't need to be transferred to a metro hospital because they needed a stent put in their heart or needed a bypass surgery or something. So we would take care of their pneumonia or their COPD exacerbation or their small bowel obstruction or pyelonephritis or whatever they were hospitalized for here in Cambridge. Over the next several years, most of those 8 providers gradually filtered out of doing the hospital side and focused exclusively on clinic. But I still wanted to maintain the hospital skills. So for several more years after that, probably from 2014 to 2019, I still worked in the hospital here, but they were specific hospitalist shifts.
Okay.
So I would cover, daytime hours, some overnights. It was, for those years, it was 28 overnights a year of, being a nocturnist, basically. And then I was a 3/4 time clinic doc as well. I haven't talked about my family yet. I'm married with 5 boys, and oldest was born my 3rd year of residency, and second was born just a few weeks before I started here in Cambridge, and we've added 3 more since then. And as they've gotten older and life has gotten busier, it was just more and more difficult to coordinate the hospital side of medicine, doing the overnights, working 1 out of 3 weekends. So 2019, I had made the decision to stop doing hospital and just become a straight primary care clinic doc. And then COVID hit, so that kind of changed things a little bit. So I went back to work in the hospital a bit when it was really critical with the hospital needs during COVID in 2020 and 2021. But for the vast majority of the time, I've been just straight clinic Monday through Friday. Since then, I've actually reduced my hours a little bit, and I'm no longer even one full-time equivalent. So I'm in clinic 4 days a week now, and helping to homeschool our boys and keep them alive and off to their activities. And
I was gonna say, when you have 5 kids, that's a full-time job in and of itself.
Yeah, so that's kind of my pathway through, with kind of showing, a lot of the different versions of what people who go into internal medicine can do. Something I have never done is that, full-time hospitalist, where there are different models, internal medicine docs. A lot of hospitalist programs are 7 days on, 7 days off. And that works really well for a lot of people, kind of lifestyle-wise. That's just, basically nonstop work for 7 days, but then you've got 7 straight days to travel and recover and go to your kids' activities and do whatever you want. But your life is kind of trashed for the 7 days that you're on.
Yeah, you were talking about it several times, and I was wondering, what's kind of the difference between like a hospital and clinic?
Yeah, so in the hospital, this has changed over time, I'd say, but a medical problem that's reached the point that it can't be taken care of in the clinic, or what we call the outpatient side. So, for example, like pneumonia is a good example of a disease that oftentimes can be treated from clinic. You might come into your primary care clinic and see me or see an urgent care, but not in the ER or the hospital, and be breathing okay, not be needing extra oxygen, and get put on antibiotic pills and get all better, and all is good after 7 to 10 days. But some people, especially if they have underlying heart disease or lung disease, COPD, things like that, they might develop a pneumonia, and it just makes them so sick that they need oxygen support, or they're not getting better fast enough on antibiotic pills. So they need to go into the hospital so they can be on oxygen, they can be monitored more closely, and be on IV antibiotics, things like that. Obviously, anything that's requiring an emergency surgery, like an appendicitis, if you need your appendix out. I mean, even that, you might get your appendix out and be able to go straight home. But things that are more prolonged infections, might spend a night or two in the hospital after a, pretty simple surgery, or some major surgeries might be like 3-4 days, recovering from an open heart surgery, things like that. So basically the level of acuity or how sick you are would determine hospital versus clinic. And, in my clinic days, in internal medicine, my schedule tends to be pretty much booked out with, for several weeks with, patients who are following up on their known medical problems. So, someone with diabetes, I'm probably going to see somewhere between every 3 to 6 months. If there are multiple other medical conditions, might see them even more frequently. Someone who's pretty healthy is just on like a blood pressure medicine or two and an inhaler for some lung disease, probably just see them once a year for their annual physical. So I have those appointments pretty booked. I don't see nearly as much acute care in internal medicine as obviously like an urgent care, or even a lot of family medicine might have more kind of emergent sick patients, but it basically just depends on how open your schedule is.
Gotcha. Okay.
At this point, most of the providers in Cambridge, at least, we'd like to hire several more providers so that we can work people in more urgently and see more of the kind of acute care. Someone needs an immediate appointment for an acute illness and see them in clinic rather than having to go to urgent care or ER. But that's a resource issue and a personnel issue and where people want to work, et cetera.
Yeah. I was going to say, speaking of which, then how many patients is kind of, how many patients do you have generally? And then like, what's kind of the minimum, maximum?
For an entire panel?
Yeah.
So most primary care doctors, depends a little bit on how many medical problems your average patient has. So my panel is a little bit smaller than a lot of others because I have a lot more patients who I see more frequently because they have more medical problems. So as technically I'm a 3/4 time clinic physician, and I think I'm somewhere between 1,000 and 1,100 patients who are attributed in the electronic medical record that I am their defined primary care provider. Some primary care providers who are full-time, maybe over 1,600 if they have a relatively healthy panel where they're just seeing a lot of them once a year. I don't have a lot of those patients.
That's way more than I was expecting. I was thinking something more along the lines of like maxing out at like 100, 120 or something like that. But then I was trying to figure out, okay, then how does the schedule get booked up if it's just that many that can't you're seeing them like 3 to 6 or once every 3 months or something like that. I'm like, they can't fill up fast at all. But that is a lot of that's a lot of patients. It's a lot to keep track of.
Yeah, you get to know people, so people who come back and see you, that's one of the reasons I chose primary care and doing, focusing more on clinic medicine rather than hospital is, really developing those relationships, walking through with your patients, whatever comes their way. Obviously we make diagnoses of, cancer and new autoimmune diseases and, really complex life-altering diagnoses. And, some of them I'm able to manage myself as a primary care doctor. A lot of them obviously get referred to specialists who I need help in designing their chemotherapy regimen, or they need to get radiation, or they need to get surgery. But, I'm kind of there as their primary care provider. I know I'm kind of the general contractor, right? I'm overseeing everything. I'm making sure that, again, one thing isn't conflicting with another, or coordinating, amongst their kidney doctor and their pulmonary doctor and cardiology doctor and whatnot, and making sure that things don't conflict, or that, everything is working together like it should.
Gotcha. Okay. And then, so then it sounds then that you're also as a primary care physician, is it right to say physician? Okay, cool. As a primary care physician, then you still get to work with a lot of other doctors and such. How does that work in terms of who gets the first dibs, so to speak, on like their kind of overall thought being the one that you guys pursue? Is it then the one specific doctor? Is it you as the primary physician? Is it ultimately, I know the patient gets the final say, but how does that all?
Yeah, so there might be a few different pathways that someone gets in to see a specialist. So one would be if they're, in the hospital. Someone goes into the ER here in Cambridge. They have chest pain. They've never had heart problems before, but it's there are concerning findings on their heart enzyme testing, and they're having a mild heart attack. So they'll get sent down to Abbott and have an angiogram with the cardiologist, maybe have a stent put in, and then they'll get scheduled for follow-up both with me for their hospital follow-up, and they'll get scheduled for follow-up for cardiology clinic.
Gotcha.
And then for the most part, the cardiologist will oversee their heart-related medications. They probably started a few new medications after the stent placement, so the cardiologist will oversee that. But it's that kind of thing I'm totally trained in and comfortable with. So if they if they need a refill on a medication and they aren't seeing their cardiologist for another 3 or 6 months, I can step in and prescribe that medication. Or if their blood pressure is too high or too low at their follow-up visit, I'm totally comfortable adjusting that medication, etc. So there can be some kind of territorial gray zone, but for the most part, we work very well together. A lot of the specialties are very easy to contact. So for example, our cardiology group that comes to Cambridge from Abbott, there's a direct hotline that we can call anytime, and there's always a cardiologist who is like reading echocardiograms or something down at Abbott, but they can also take time to take phone calls from anywhere in the Allina system across the state. So lines of communication are very open in that regard.
Gotcha.
Other patients might see specialists because I specifically refer them. So if I have a patient where they're presenting with some sort of autoimmune disease like a rheumatoid arthritis or lupus type of symptoms, and I do the evaluation. They don't just come in and see me for the symptoms and I say, well, you need to go to see rheumatology to figure this out. Like I will do all the evaluation that I can, usually either rule out the autoimmune disease completely or 100% rule it in. Like, I know you have lupus, all your tests show that you have lupus, but you need to see a rheumatologist to get the expert guidance on how to best treat this. Or there might be kind of a gray zone, like, it looks like you may have lupus, I'm not 100% sure. We should send you to the rheumatologist to, make that final diagnosis, rule it in or rule it out based on their expertise. So that's kind of the other pathway that someone might see a specialist. And then, again, kind of territory-wise, they'll at least prescribe the initial treatment. A lot of times, that's kind of all we need is get that initial guidance, get started on treatment. And then if it's, something that, patient is doing well on treatment, they may not even need to see the specialist anymore. They just may continue to follow with me, year after year for that condition.
Because then you might have an idea then of the treatment and how it should proceed then going forward. Okay.
Yep.
Gotcha. You're talking about different specialists and such. What are your thoughts on kind of just the more holistic side of healthcare, whether that be, I don't know, if chiropractic kind of stuff falls in line with that, but just, that spectrum.
Yeah, so that was something that I really wrestled with in college, actually, was whether to do more of a, kind of Western medicine, I guess traditional kind of could be traditional, like like traditional Eastern medicine, things like that, versus, what we consider Western, like quote unquote modern medicine, versus going into chiropractor. Was actually looking at chiropractic school was something I did. So something a little more integrative and holistic, because I really was interested in more health promotion, wellness, overall preventing disease rather than just picking up the pieces. So it's kind of interesting that I've, internal medicine, like I said, is just very much, based now on treating chronic conditions when they've set in. And, oftentimes once they're too far along, like you can take steps to improve health. And I've really, really worked with my patients on doing that. But oftentimes we're, very limited. Like we can't go back and reverse COPD, for example. Once COPD is there, yes, we want people to quit smoking. We want them to do pulmonary rehab. So there's like a specific exercise program and education program that's really helpful. But we still have to continue the treatment for the disease lifelong because it's a chronic illness, unfortunately, that we can't completely make go away. In my own practice, I'm not at all opposed to working with the local chiropractors, integrative medicine, whether that's within Allina Health or sending to other kind of holistic medical practitioners in this area, or if someone is seeing a provider, right in the metro area. I have a couple patients who are seeing a integrative medicine clinic in Bloomington in the South Metro, et cetera. So very much promote that aspect of them, taking control of their health, really working on implementing everything that they can, lifestyle-wise, physical activity, healthy diet and nutrition program to minimize the burden of diseases that they accumulate over the years.
Okay. And then as you're talking, it seems like, since you're on the clinic side of things, it sounds like you get a lot more time to kind of build and develop trust with your patients than you necessarily get in the hospital side of things. But it feels like then the risk of losing that trust can also go up too in terms of just longevity of memory and stuff like that. If patients are like having a hard day or like, I don't know. But I guess the question I'm trying to get across here is then, how do you specifically kind of develop and maintain your relationship with your patients then?
Yeah, so I'd say, I'm very sensitive to what are the frustrations that my patients are likely to experience in medicine, seeing me. So I'm, obviously wait times. We talked a little bit about, how long it might take to see me as their primary care provider. They have a new symptom and would like to be seen sooner. And, ideally, not to be, arrogant, but, they would like to see me because I know their medical history. They like to see me rather than going to urgent care. I would like to see them because I know the context. I, hopefully have a better sense of, can kind of get to the bottom of everything quicker because I know their medical history. I know the journey that we've already been on together. But sometimes, there might be a longer wait than I would like and that my patients would like, or getting them in to see, like I've reached this point where I know I've gone as far as I can with this evaluation. The next thing is we need to get you in to see, a specialist, or we need to get you this specific test done. And we're waiting longer than we'd like to because there's kind of a log jam in that, or there's a shortage of that specialty. So those are things that, maybe not trust per se, but can certainly be frustrations with just the health system or with how quickly I'm able to move things along for my patients. Obviously, just reaching a diagnosis, like I said, internal medicine is kind of like solving a puzzle, figuring out maybe a complex constellation of symptoms. And, sometimes it takes longer to, sometimes there's something very obvious. Someone comes in with a sore throat and, you can tell by looking at their throat and, do a rapid strep test, and 10 minutes later, yep, you have strep throat. Yep. Here's your amoxicillin. This was easy, right?
There you go, yep.
But, oftentimes there are, underlying symptoms, funny abdominal pains, or I don't want to give too many patient-specific examples of things I've seen recently, but, there could be many different reasons for, like, sometimes fluid accumulates around the lungs, so pleural effusion, and there are dozens of things that can cause that. And usually with a fairly limited amount of testing, we can arrive at a diagnosis of why that fluid is accumulating. But sometimes it takes longer. And actually, recently, it took doing a colonoscopy of all things on a patient of mine to determine why they were accumulating fluid around their lungs, and they were leaking lymph fluid out of their intestine, protein-rich lymph fluid, and they had what's called intestinal lymphangiectasia. And that was causing their protein to go low, which causes a complex interaction of oozing fluid into what's called the pleural space and accumulating a pleural effusion. But it took months to ultimately get that colonoscopy done and to arrive at that diagnosis.
I was gonna say, is that hard then to like kind of with both you and the patient of something taking months, or like I'm sure you've become familiar with like the kind of the time span of figuring out an answer, but how often does that become frustrating for like patients?
Yeah, and hopefully it doesn't take too long for most of the time. Most symptoms, we hammer down a diagnosis relatively quickly, and make a treatment plan. Kind of same thing. Some diseases are pretty straightforward to treat. Like an antibiotic for an infection. Generally pretty straightforward. Certainly there are some more chronic symptoms that just finding the right treatment for that particular patient, because all of us are incredibly complex and nuanced, can be a little more challenging. So, I mean, I think of, I don't know, like I'm not very mechanical. So, if my snowblower rotor isn't turning in the winter and I need to snowblow my driveway, I go to YouTube and, watch the videos of the people who know this stuff. And they're like, well, there are, 10 things that could be causing this problem. So start with number one, the easy thing. And, you rule out that the little pin on the rotor hasn't just broken, because that's easy to fix. And then you keep going up the chain to more and more complex things. And that's, somewhat similar to how we approach a lot of things in medicine. Either take the low-hanging fruit, the things that are the most likely, the most common, and or the easiest to reverse, and evaluate for those first. But if we get a panel back of labs and imaging that are completely normal, and we didn't get an explanation for the symptom, then we go up the chain and we look for the less and less common things, or the things that are harder and harder to test for, that maybe requires, instead of just taking a picture, taking a biopsy or a sample of something that has to put the patient through some discomfort or suffering just to get at the diagnosis. And we could do that up front, but, then we'd cause a lot of people unnecessary procedures and unnecessary harm when we could have gotten the answer sooner. But then in retrospect, people are like, well, why didn't we just, jump to the test that actually sealed my diagnosis in the first place? Why didn't we do that first? And so kind of explain that stepwise approach and whatnot.
And then you talked about, you have to connect with, the patient's other different doctors that they might be seeing and specialists that they're seeing. I talked about kind of just the various other people you have to interact with on a somewhat regular basis for your patients. But who kind of make up your main group of interactions and or colleagues in a given day?
Yeah, so here in Cambridge, whenever possible, we keep the care local just for the convenience of our patients. I guess I don't know the exact average age of my patients, but in my panel, it's probably early to mid 70s, I guess, for average. So just not quite as easy to get down to the cities for consultations or procedures, things like that. So if we can have them see, a specialist in Cambridge, we do that. And we've got a Pretty good list of services that can be completely taken care of locally. So clinic visits with cardiology, some limited pulmonology, lung disease services, some limited GI services. We can do colonoscopies and EGDs and GI procedures in Cambridge. Um, you know, Many of the surgical specialties, general surgery, orthopedic surgery, GYN surgery, ENT, ear, nose, and throat, who does a lot of head and neck surgeries. They come to Cambridge. Um, I'm not going to give a exhaustive list to be kind of boring, but some of the things where that we don't have that do require traveling more to the cities are things like endocrinology for complex hormone problems. And a lot of endocrinology is managing diabetes. In my practice, I take care of 99% of my diabetes myself. I don't refer to endocrinology. Um, but for people who are seeing an endocrinologist because they have other complex hormone problems, they go to the North Metro. Mostly these are in Coon Rapids, so it's not super far. Rheumatology, we don't have any rheumatology services in Cambridge. Those are two of the big ones.
Okay.
In terms of specialists that we can still coordinate. At other sites within Allina, or referring outside of Allina if someone really has a complex issue and is going down to Mayo, we'll coordinate referrals to Mayo or the U of M, etc. Transplants would be another thing. There are a few transplants that are done within the Allina system, but a lot of transplants are down at the University of Minnesota or at Mayo. So I have a number of transplant patients in my practice who have obviously really complex medication regimens. They're on medications to suppress the immune system so they don't reject their transplanted organ, which then can open the door for other complications, etc. So working with those teams.
Okay. All right. And then with a lot of this, then you have to have a lot of knowledge both on your patient and also just the potential different causes and then also the potential different answers to the problems that they're having. Do you have to, how do you maintain kind of that knowledge? Do you have to do like certain amount of hours of like continued ed a year? Do you go to like, I know dentists have their like conferences that they go to all the time. How do you maintain being on the cutting edge?
Yeah. So there's both formal continuing medical education, or CME we call it. So every 3 years we report to renew our license that we've completed the required number of CME hours. So that's all validated, and can do that at medical conferences, which can be in person or virtual, or can even acquire CME through like audio courses, listening to lectures from home if you're not traveling, things like that. Doing reading or online modules, you can apply for CME through those activities. But there's a lot of just on the fly, kind of reading up on things. You see a medical condition that you haven't encountered in a while, and whether out of curiosity, if it's something that you're not seeing very often, it might be, as a primary care provider, it might be something you refer to a specialist, or it might just be reviewing. I know there have been a lot of new medications, developed in this area. What's kind of the cutting edge? Because it could very well be different than when I was in medical school in 2003. So that's medicine is ever changing, and there are new medications coming out. Just learning more and more, even about very basics. Like not a new medication, but who should take aspirin, right? Like when I was in medical school, like pretty much everyone should take aspirin to prevent heart attacks and strokes, and now it's a different story, right? So we don't recommend aspirin for someone who doesn't already have a cardiovascular condition or who hasn't had a stroke or a mini stroke before.
Gotcha. Okay.
So things even on very basic treatments change.
Yeah. Okay. And then are there like any like tools that you use to kind of like quick kind of refresh yourself? You were saying, you'll go through the courses, but then if there's like, some random symptoms that you haven't seen combined in a while, like how do you kind of research that?
Yeah, so there's probably the number one used medical resource, the very, current up-to-date information appropriately is called Up to Date.
Right.
So this is a database of, articles, kind of review articles on every medical condition under the sun that's written by specialists in that area. So it's, comprehensive. If you, low sodium level, for example, this is like, last I heard, this was the number one looked up to date article was hyponatremia, which is the medical term for low sodium. So there are all kinds of things that can cause your body to misbalance the amount of sodium and water in your bloodstream. And it's kind of a interesting physiology. It's in the world of nephrology, or the kidney doctors kind of manage these electrolyte disorders. So there's an algorithm on how do you evaluate and treat the whole variety of causes of that medical condition, and that gets referred to quite often by both clinic and hospital doctors.
Huh. Interesting. I was just thinking about the low sodium thing. I was just watching a video about a guy who's doing the meat diet, and how one of the things that he realized that he was doing wrong was not taking in enough sodium as a result of the diet, and then his whole system started to malfunction. So
Right.
just think about it, yeah. Just even the small things of salt intake can just be detrimental.
Yep.
If you do or you don't.
Yeah. So lifelong learning, definitely. If you don't like learning and reading and staying up to date on stuff, and want to learn something once and be done learning for the rest of your life because you already know how to do whatever it is that's involved in your job, medicine isn't going to go well for you, because you'll be practicing outdated medicine for most of your career.
Yeah, which isn't
Not work
ideal.
well.
Isn't ideal. All right. I'm trying to collect my thoughts here and see if
Um, in terms of like just what medical school itself, like if someone is interested in medicine, like preparing for med school, or what to expect in med school, or other medical careers, even like PAs and nurse practitioners, how they function, would be potential topics. The structure of med school with kind of book learning versus hands-on practical kind of application rotations, stuff like that. That would be delving out a little bit just medicine more in general versus kind of focus on internal medicine. Yeah.
No, let's hop on that. Let's see. I'm trying to remember your last thing you said.
Lifelong learning.
Lifelong learning.
So kind of what you learn in med school is not the truth 20 years later.
Yes, yes. Speaking of lifelong learning, we talked about this already. You've gone through 4 years of undergrad, 4 years of grad school, and then 3-ish years of residency. What was kind of like the learning process for you, and what kind of helped you? What kind of hurt you, and what's still relevant to this day for you?
Yeah, so just kind of basics of med school for those who don't know. So you get whatever your degree is for undergrad. I was kind of a boring biochem, which doesn't really set you apart much in applying for medical school. There may actually be benefit to having something a little more diverse or unusual than a science degree. So like if you're an English major applying for med school, you're going to get a lot of interest in how did you go from English to med school, or what are your experiences that bring you to interest in medicine, and really having a kind of well-rounded, right, that cliche term, well-rounded resume to boost your med school application. Once you're in med school, you're, at least most med schools, as of when I went to med school, which was quite a while ago now, was 2 years of pretty straight classroom time of just intense learning physiology, pathophysiology, histology, looking at what all the cellular tissues look like under the microscope, learning anatomy, where all the blood vessels travel in the body, all the bones, all the joints, all the tendons, everything, medicine related. And then really the fun part of med school starts your third and fourth years where you're doing the clinical rotations and getting experience in the whole vast array of medical specialties. Because there's kind of something for everyone in medicine. I mean, there isn't a specific personality or anything. You can become a diagnostic radiology who never interacts with people if you're more of an introvert and like to sit in a dark room looking at pictures all day of chest x-rays and brain MRIs and whatnot. But even within radiology, there's more interventional radiology now where you're constantly doing procedures and things like that. You're interacting with patients all day long. Pathologists who are looking at tissue slides from biopsies and skin biopsies from the dermatologist or tumor biopsies from the oncologist, et cetera. All the surgical specialties, all the medical specialties. So that's kind of the initial learning that I underwent in med school. And again, after all that, came away thinking internal medicine was the best fit and went on to the internal medicine residency.
Was that kind of you just thinking through it, or were you kind of bringing people into like talking to your professors and stuff like that? Or?
Yeah, it was really kind of talking to once you narrow your interests a little bit, and so I'd found like the spot decision making, very decisive, that you have to be a surgeon, right? You're going to encounter whatever's going on in the OR, and you just have to be on the spot, quick thinking, know what to do immediately. Same thing in the ER, right? Like you're under pressure, emergency, things like that. Like I prefer to take my time. I'm not as decisive. I like to spend time solving the puzzle, like we've talked about. So really just found that internal medicine was a good fit, and then getting all the experience that you can, whether that's during your clinical rotations, generally students kind of identify, a couple of their top interests, and then they might do what's called a sub-internship in that area to really, make sure, meet lots of providers in that area, talk to them about what life is like in that. There's kind of a saying that, you can like, 50% or 80% of a specialty, what you're going to do, but what's really going to make or break it is, can you tolerate the worst part of that specialty? So if you, I don't know what a good example is. If you want to become an orthopedic surgeon because you love doing, fracture repairs, but you can't stand doing, elective hip or knee replacements, like you're probably going to have to do, you're probably going to have to do some of everything. Yeah. So don't sign up to do something that you just absolutely can't tolerate doing all of the job, even if it's a small percentage. Yeah. And obviously there's some flexibility in how you tweak your practice as you get established. Some people, ultra specialize. They go into neurology, brain and neurologic diseases, but then they end up like, I only take care of migraine patients, so a tiny subset of neurology, and I never see the stroke patients or the MS patients or the Parkinson's patients. Or, I only do movement disorders like Parkinson's, and I don't do any of the other stuff. So, gotcha. So you can super ultra specialize, but then you don't have the variety and diversity. So I like seeing a whole variety of conditions. So that's why I did general internal medicine instead of specializing. we talked a bit about, internal medicine. Coming out of residency, you can, if you want to do general internal medicine, you can be a hospitalist or clinic or do some combination. But a internal medicine residency is also the foundation for doing a fellowship in any of the medical subspecialties. So that's cardiology, nephrology, pulmonology, rheumatology, endocrinology. There are several more that I'm missing off the top of my head. But that's another, for most of those fellowships, that's another 3 years. And then some of them, like again, ultra specializing. So you might do a 3-year cardiology fellowship and then do even more training in interventional cardiology, where you're in the cath lab all day and you're not doing other cardiology problems, things like that. So you can basically train until you're 35 if you want to, and then get your first real job.
Oh gosh, yeah.
Or if you plow through, if you don't take any breaks and do your undergrad and then straight to med school and straight to residency. So what was it? I was 30, I guess, when I started my first job here in Cambridge out of residency. So that's kind of the youngest you can be before you finish, just in terms of timeline of interest.
Is the job market pretty good in terms of, or was it, I guess, 14 years ago, you graduated, applied for, did you apply just for local areas, or were you kind of shooting all over the place? And
yeah, I think for the most part, at least for primary care, I can't speak exactly to all of the specialties, but in Minnesota and the metro area, I think there's a demand for just about everything. So if you have any medical degree and you're trained and you're board certified and you have good references and all the typical resume stuff, you're almost certainly going to get hired in your area of specialty. Primary care is certainly a growing need. There's I'm not completely up to date on the trends in terms of what specialties med school grads are going into for residency. It's called the match. So you apply to your area of interest for residency, and then they match you to a program. It's a really complex process, but it works out pretty well. But as of the time that I was completing med school, there were fewer and fewer people going into the primary care specialties and more people going into more of the medical medical and surgical specialties. So more like ENT, orthopedics, dermatology, surgery, things like that, and less family medicine, internal medicine, OBGYN are kind of the classic primary care specialties. Kind of a lot because of work-life balance, things like that. So kind of, people really being forward-thinking about what's going to, allow me to, have a very, worthwhile and rewarding career, but not, have some control over schedule and things like that. Yeah. So that's a big consideration. And, there are a lot of efforts going on to, ensure that primary care remains a adequately staffed and good area of medicine to go into in terms of that balance.
I was gonna say, and then with and feel free to answer as in depth or out of depth. That's not right, but as in depth as you want to for this next one. But I know it's not cheap necessarily, no matter what route you go through medical school, just with wherever you choose to go, and you got 8+ years of education. How does it pay off, I guess, in the end financially?
Yeah. I mean, there are statistics out there about what the average med school grad how much debt they come out of school with, which I don't know what the absolute current value is, but it's a lot, well into the 6 figures, which There are certain, that's a choice to a large degree. And I mean, I was in med school, I was single, I didn't have kids. Like I said, I got married my first year of residency, and my first kid was born my third year of residency. So I had at least some income at that time. Residence income is not great, especially considering the number of hours that you're working. So
Mm-hmm.
turns out your hourly rate is like below minimum wage. But during med school, you can choose to live in a, luxury apartment, or you can choose to live with a roommate in a non-luxury apartment and save
Mm-hmm.
money. So you can make some of that decision. When do you choose to buy a house, or what car are you driving? Obviously, all these decisions individuals make. I didn't feel rushed by any means to live a quote unquote doctor's lifestyle during med school or residency. So just my personal preference is to not be have large amounts of debt and whatnot. So I was very fortunate to not be. I wasn't debt free coming out of med school, but was well below the average.
Hmm.
And by delaying even by a couple of years, after getting your first real job, delaying a couple of years, you know upgrading your car and things like that, you can really pay off a lot of that debt faster if you
Mm-hmm.
want to.
Yeah.
Depends on interest rates and all that stuff. Paying off high interest rate loans at least makes a lot of sense. For me, I can say I mean, I've been out of residency for 14 years, and I just chose to really plow through, and I didn't just pay my monthly payments on my student loans. I accelerated that a lot,
Mm-hmm.
basically paid off as much as I could, as fast as I could. So honestly, within a few years after completing residency, I had paid off all my student loans, and went on to buy a house and whatnot. So there's a big variety, big variation in the pay of different medical specialties, but they're all, the reality is, very well paying. There's a lot of talk about, in primary care, should we be compensated for the work we do outside of our clinic time?
Mm-hmm.
So, that's kind of a big, primary care is probably the most challenging in terms of work-life balance, because it's not shift work. It is longitudinal, and you have results coming back to your in-basket 24/7. So literally, no matter when you log into the computer, day or night, you have work that could be done. So how do you package when you do that work?
Mm-hmm.
And the reality is there's more work to do though than can be done during your straight clinic hours.
Yeah.
If you're booking your patients for 8 hours a day, and seeing patients during that time, there is no physical way to complete all of your notes and respond to the phone calls and the in-basket messages and the results and everything else to complete it during your shift. Whereas if you're an urgent care provider or a ER provider or a hospitalist, you're on the clock and you complete your work and you hand off the patients who are left in the ER or whatever to the next provider, and you go home and you're done with your work
Mm-hmm.
until you go back in. And in primary care, you're always following up on results and everything.
Yeah, I remember a while ago, Jackie got some like results back, or my wife got some results back, and it was like 11 something at night, and I was just thinking to myself like, wow, it's awesome that we got the that you know we had the results, but at the same time, like, go home, doctor. Like we thank you for your service, but now go to bed. How do you work on that work life balance? How do you have hobbies? Do you have other stuff that kind of helps you keep going?
Mm-hmm. Yeah, so logistics of trying to consolidate work as much as possible. Mentioned I did reduce my FTE a couple of years ago now, which was just a great move. There wasn't any need for me to work full time, and let's be honest, if you're working full time, that's not 40 hours a week as a physician. That's like 60 to 70 hours a week. So going down to 3/4 time is, it's not 30 hours a week. Both in terms of, seeing patients and then doing the leftover work. Kind of the rule of thumb, they've looked at this for every hour a primary care provider is seeing a patient, they're doing 1 to 2 hours of work outside of the direct patient care time.
Oh man.
So
Okay.
it just really, it adds up.
Yeah.
So for me, reducing the overall, FTE, which, I still see patients 4 days a week, but I have 1 full weekday off, not in clinic. And I did that because, so Monday is just my boys' busiest day with activities. So they have their American Ninja Warrior type practices on Monday and Boy Scouts. And every night of the week we've got something. So having fewer clinic hours is helpful. And then, I can get out of clinic. I still have a lot of work I do from home or when I'm, at my kids' practice. I'll have my laptop and be logged in, getting out result notes and things like that.
Okay.
But, able to kill 2 birds with 1 stone, get my kids where they need to go and have some time to do productive work as well. Hobbies, that kind of gets into hobbies. Like I said, we homeschool our kids. I guess that's not really a hobby, but that's something that is a time consumer, more for my wife than for me, by all means. But I've chipped in various ways over the years on this homeschooling journey, from teaching science to, just my job to keep the littlest one, who's not quite in kindergarten yet, occupied. So Carrie can actually accomplish things with the older boys. We got very much involved as a family in the ninja gym, or American Ninja Warrior style ninja competitions and practices. So we actually all do that now. It's an amazing thing that all my boys like the same sport, and my wife and I do too. So we've got it's a family endeavor, and we spend lots of time there at various age groups practices. The boys are all in Scouts, and I'm the Cub Master for the Cambridge Cub Scout Pack, and I also work with the Boy Scout troop that my older boys are in now. So we're very much involved in that, and Carrie's on the leadership team for the Cub Scouts as well. I've always been a runner for my whole life. Well, not my whole life. Like I said, starting in high school, running cross country and track, and that was part of the stimulus to go into medicine. Do less running now as I engage in more ninja practices and competitions, but still like to get out for a run. Those are kind of
Sounds like quite a lot.
big hobbies.
There, yeah. There a healthy amount of competition then within the family then for ninja. I'm until 2 years ago, probably when Isaac was 13 or 14, around 13 is when both of my boys have definitely shown me that I'm not the best at everything athletic anymore. So Isaac and Caleb can do most ninja obstacles better than I can, is if it involves movement. If it involves being fairly stationary, like holding a lock off, we call it. So if you're like doing a hang from a bar and go halfway up, or keep your chin above the bar, I can do that a little better than they can still, but that's probably going to go away pretty soon too. I was gonna say that's a lot of stamina. I've looked at several of the videos of that, and a lot of stamina, a lot of coordination, a lot of just swinging around. But it looks like a great time.
Yeah, for anyone listening, if you have a local ninja gym or American Ninja Warrior gym and you haven't gone, I recommend checking it out. It's a lot of fun.
Okay. And then as we're starting to wrap things up here, kind of like the final sets of questions that I have is just kind of what's something that you've piece of media that you consumed, whether that's a book, song, movie, or something like that, that's kind of made you step back and think of it.
First thing that comes to mind is a book that my wife and I read together. It's a few years ago now, but called The Eight Great Smarts by Kathy Cook, Koch. And what was eye-opening about that was, that intelligence isn't just book learning. So, the reason I could excel in high school and college and get into medical school was I was naturally gifted in a specific set of skills. And in Kathy Cook's kind of organizational scheme, those are logic smart and word smart. So I had kind of the typical, classroom skills. But there are 6 other areas of being smart that may not be typically seen as, intelligence or smart. And I may not be able to remember all of them, but they're things like music smart and body smart and nature smart and people smart and self smart. And I think there's one more that I'm not thinking of off the top of my head, but that was just really eye-opening, that to really invest in, whether it's in homeschooling or helping your own kid through school and identifying what their gifts are, and not labeling someone as, not smart because they have a difficult time reading. They're actually probably really smart in some other domain. They may have incredible, body control and be a, pole vaulter or a gymnast or a ninja or whatever. And that the brain just really thrives in a different area of intelligence than, reading or solving math problems, things like that. So I recommend that for anyone interested in how different people are made and created and where their giftedness is.
Okay, and then you said that's 8th grade smart?
Eight great smarts.
Oh, okay.
8 great smarts.
8 great smarts. Kathy Cook. And finally, for the final question, just give us, in like 2 minutes or so, why, kind of just sell yourself, why is it important to have a primary care physician? Why internal medicine? Sum it up for us.
Yeah, that's an interesting question. Very appropriate now with the, explosion of virtual care, medical care that came about because of COVID and minute clinics and things like that. And maybe if you, really don't have any medical concerns and you really aren't interested in engaging in getting your routine labs checked and things like that, you just want to go in when you've got a sore throat or a broken bone or whatever. Urgent cares and minute clinics can provide that. But I really think people should take charge of their health, get a set of labs every year, full physical. Unfortunately, we have to navigate kind of this world of insurance and what's the cost of checking labs. I would like to do a whole set of biomarkers on everyone and identify, risk factors based on your family history, minimally abnormal labs that may still be within the normal range on the lab test, but that doesn't mean they're optimal. So, even if you're in good health, you don't think you need a regular doctor. Identifying things early, really talking with someone who is interested in, again, taking that, upstream wellness approach and engaging with them to come up with a plan of, what do you need to do to maintain optimal health? And, don't wait till it's broken. It's my take-home message.
All right.
Because like I said, I just deal with the very far gone downstream effects.
Yeah.
That not always, but sometimes we could have intervened earlier and really improved someone's life in a big way.
Okay. Awesome. Thank you again, Dr. Peltier, for just hopping on the show and just chatting about what it means to be an internal medicine doctor.
Yeah. Anytime, Jake. Thank you.